about. We did talk about some of these in some other lectures, and one's just to be aware of. These are on your syllabus for phase 2. So there are some hidden slides or some other things or things that you will be responsible for phase 2, but we are not going to do them here. We'll leave that for nephrology. So UTIs in kids. You're thinking, oh my gosh, we've learned UTIs, we're blue in the face for this. Good. Let's just make sure that we still remember that if it is just the bladder, we're talking about cystitis. If it is the kidneys involved, you have pyelonephritis. All of that is the urinary tract. So a UTI is just that long term. If you think about that most common bug, it's going to be E. coli, especially in kids. Think about these kiddos. They're sitting in a diaper. They're learning how to have good hygiene. They're learning to wipe. So particularly for these kids, E. coli is going to be your number one guess. Unless you know this child has something anatomically wrong, then start thinking about other things. So if a test question or in life, they tell you, this child has had something anatomical, or this child has had a previous surgery for fill in the blank, and it has to do with their GU anatomy, that's when you start thinking, if they're trying to tell me it's probably a different bug. Otherwise, think E. coli. Who is at risk for these urinary tract infections? Well, certainly if you are under a year of age, it's most of the time kiddos that have that anatomy that is incorrect. Something has gone wrong. So you have something that's going retrograde, so a VUR type presentation or some sort of other anatomic abnormality that is causing the system to malfunction. The other group is going to be uncircumcised males, so this is going to be one of those things. Versus after a year of age, it switches and it is mostly little girls given their normal anatomy. So just by the epidemiology, it's going to switch at that. And again, you see this at those like 3 periods of time. So much like you saw constipation happen when they were starting solids, when they were starting toilet training, and then starting school, you see UTIs clustered in those 3 different types of periods of time. Early infancy, when there's something anatomical going on. You see it with toilet training again, given the hygiene, and then you see it with a sexual debut. So kind of those 3 time periods again in children specifically. The ones I want to point you to here, again, so you know female gender, that's going to make more sense, obviously. Uncircumcised males under a year, so that's a particular one there. If you have VUR, we already talked about when you're toilet training. I want another one. Oh, and then highlight star everything constipation. So when you have that massive amount of constipation that we just talked about, it can block the outflow tract. It can also cause some of the abnormal response where really at a neurogenic level, all of the signals are messed up for these kids. So you have a lot of UTIs associated with true chronic constipation. So this is where GI and GU kind of cross. Again, only bladder is going to be involved. The problem with this for kiddos is that it's really hard to look at a 1-year-old and be like, do you have any dysuria? Do you have any urgency? Do you have any frequency? Right? You don't have that history. So a lot of times, especially for babies, you just have discomfort. You just have them irritable from block 1. So if you think back, the crying infant, the colicky infant, this was why that was the only lab. They can't tell you this. So that is why that's on your differential, because they are not able to give you a history that an adult or even an older child could. It hurts when I pee. I have to go all the time. This is what's going on. Oh my gosh, there's another one. I am shamed today. I am shamed. There is deep shame. Oh my gosh, I'm using my red pen. You guys are in my pen over. You know how much I love my red. Should have seen it when I got here a year ago and here to some of these slides, and they were all over. And I still have them. I am shamed. I just want you guys to know. Public vlogging. When you have the renal involved in, now you're at pyelonephritis, it can cause that renal scarring because you have that inflammatory response from that infectious process going on in the kidneys. This one A little bit more severe because now your filters are involved. So it's not just your collecting tank that is infected, now your filters are actually involved. And so systemically, you feel terrible. So the kids feel terrible. So a lot of abdominal pain, nausea, particularly with this one. And the infants are really just gonna say, I feel so sick, I'm not gonna feed, and I'm just gonna lay here. So that is one of those workups for those septic infant looking things, again from back in block 1. Would be pyelonephritis for that particular reason. If you have the fever without a focus, so you don't know what's going on, this is again why the UA is part of that workup, because it can be the most common source of that fever without a source. So we're getting those UAs and we're getting a urine culture. And you remember, you have to marry those up in peds. Those have to go together. They will never unstick as long as you are alive in peds. Urine, UA and urine culture must go together because a child cannot concentrate the urine. So if they're in a diaper, they're just peeing whenever they want to. So nothing is staying concentrated. So your UA is going to look very different in children than in adults. And so you have to have that culture that's going to grow over time to actually show you what's going on. They also can't do a clean catch very well. So under the age of 2, you're going to collect this with a straight cath. So you cath them in and out. So all of those should be cath samples. And if they're over the age of 2 or toilet trained, then you can try to use that clean catch. A lot of people will say, hey, I have worked somewhere and we used a bag. What happens when you use a bag? You get skin flora. And how many cells do you need to completely invalidate your sample? Yeah, 3 to 5. Do you think you're going to get more than 3 to 5 skin cells from a bag? Yes. So now you have a contaminated sample that you functionally can't use. So it happens all the time, just not a great sample because it's very, very difficult to interpret the results. Contaminated often. Okay, well, great. Well, I don't have the specific things, so really what am I looking at for a child? So in a child, the way you're reading a UA is going to be a little different. If you have more than 10 red blood cells, white blood cells, 10 white blood cells, high urea, that's considered a positive finding. So an immune response in the urine is enough to say, yep, something's going on there. Certainly if you have leukosterase or nitrites, certainly that is helpful. However, that is a byproduct of the bacteria after it's been concentrated in the urine. So again, children aren't doing that, so it's just not a great indicator always for children. Very specific, not very sensitive for children. And then those epithelial cells, again, often from the bag, really functionally invalidate your sample. That's why you need that culture. So you are looking for more than 50 colony-forming units. So that's kind of your magic go-to there of that one pathogen. So I'm looking for that E. coli, I'm looking for that Proteus, I'm looking for the Klebsiella. More than 50,000. Certainly if you have an older child, and older meaning they're toilet trained, they did truly get a good sample going on. So some people will say over the age of 10, some people will over the age of 5. We'll call it school aged. I'm not going to try to trick you with that. I'll try to give you under a year or over a year. And if you get those in between, most of the time it's that contaminated sample and you have to redo it. So that 1,000 to 50,000, really not helpful. So well, please use a straight cath. Your antibiotics are then going to be for those kiddos who are over 6 months of age and have that positive urine culture. So it's going to be your oral outpatient antibiotics. What about those kids that are younger than 6 months? Well, if you're younger than 6 months and it's positive, we're really worried that your filters are going to get infected, so you've bought yourself an admission. Under the age of 6 months is going to be an IV antibiotic, and it's a pretty long time. If you're looking at the neonate who has the filters involved, you're also worried about that blood-brain barrier. And so you're watching them for a significant amount of time, almost 2 weeks for this. Your older kids, you're still watching them for a week to 2 weeks, certainly if their filters are involved. If they're no better, you're doing this as an outpatient, you have the presumptive cultures back, and they're really not any better in 2 days, then you need to repeat it and make sure you're starting to get some sampling at that point of not just the urine, but radiology as well. What's going on with those kidneys? What's going on with the rest of the things that are trying to process this urine? Yes, you're going to make sure that you've looked at the antibiograms. Yes, you're going to make sure that you are looking at your culture results. If you do not have that in your empiric treatment, in a clinic, in an urgent care, in an ER type setting, your go-to is going to be ceftonir. Is that same one that we talked about for ear infections. This is also the one that turns your stool that clay Sedona red color. So it's a very confusing picture then when they're already looking at the diaper freaking out, and now they have this Sedona red clay colored stool. So again, something to be mindful of. Can use a Moxclav, more resistance there. Certainly Bactrim is going to be lower on the list, especially for younger kids. Ceftonir is really what I need you to put in your mind. And really nitrofurantoin or macrovid, not used for kids very much. Why? Because it works in the bladder, so you have to be able to concentrate that urine to be able to work on it. Kids cannot do that, that's why it's not a great choice for them. Fantastic choice for teenagers, fantastic choice for young women, terrible choice for young babies, terrible choice for young kids. You can't concentrate. And then for parenteral IV, you're using your ceftriaxone. It's going to be your go-to. Certainly your hygiene is going to always be something that you are thinking about, but really I need you to go back to what's often the underlying cause. So for children, it is going to be constipation. See previous lecture. Treat the constipation, you will oftentimes fix their urinary symptoms. If they have VUR, and we'll talk about that shortly here, VUR is going to need some prophylaxis, but more to follow on that. More common, again, for bacteremia when your filters are involved, because they have access to all that blood, so you're seeing that. Uncommon to have an abscess, something you can't see there sometimes. And if you're thinking, is this recurrent? Does this happen more than once? I usually say everyone gets one UTI for free, but after that, I'm just really starting to think what's going on with your anatomy. So if it is recurrent, I really want that renal bladder ultrasound, and I'm starting to think, do I need a VCUG? Did you guys learn about VCUGs? Okay. So when I'm thinking about, okay, it's my second one, but what do I do on that first one? So that first one is kind of your free one. Especially if you're toilet training, you don't need to get any imaging. Okay, so you get yourself a free UTI, especially while you're toilet training. You assume that there's a hygiene issue. We're okay. So certainly if you're under 1, that's not who we're talking about. If you're older, you get your free one. Toilet training, that's a weird era. You get 1 free one. After that, and yet your first line is going to be your renal bladder ultrasound. The second line, if it continues to be recurrent, if you are, if it's abnormal, so if your renal bladder ultrasound is abnormal, if it's recurrent despite a normal one, or if they're under that year and you're working with nephrology, those are who's going to be getting those VCUGs. Do you remember how they work? No? Yeah, they're very, very uncomfortable. I thought I had a slide too, but maybe not. They're very, very uncomfortable. So they are functionally shooting dye up into the bladder and seeing how far it travels up. So it shouldn't travel at all, surprise, spoiler, but if it does, that's when you're starting to be able to grade that. VUR is happening when you have vesicoureteral reflux, so it's going in retrograde. It should not be leaving the bladder and going back up. It is in these children. Thing to know about this is that oftentimes if you see hydronephrosis on a prenatal ultrasound, they're slightly higher for having VUR as an infant. So those are the ones to watch specifically. And often all of that is because they have a UVJ obstruction. So that juncture between the two is really functionally just very immature. And it really, over time and as they grow, that junction matures. And so it is able to handle that better. As a reminder of what that looks like, if you have that junction, you might have one side that is normal, however the other side can have a problem. It can look different, you can have different grades of VUR on both sides. We'll talk about that. Oh, I did put it in there. This is very, very uncomfortable. Has anyone seen a VCUG here? It is so uncomfortable for these children and adults, so please give people something. Don't make them just go through that, especially children. Please sedate them. So this is looking for how far back is their reflux for you. So grade nothing would be they put the dye into the bladder, they take a series of x-rays, and there is nothing that ever leaves the bladder. That's no VUR. Grade 1, you have some, and it goes some up the ureter, leaves the bladder, some up the ureter, but not all the way. Grade 2, all the way to the top of the ureter, no dilation. Grade 3 and 4 is very difficult, and that's where the radiologist is going to tell you how much dilation there is between grade 3 and 4. And then grade 5, one of my favorite words, tortuosity. So it's so dilated that you see kind of a snake-like movement of the ureters. So that is how you are grading those. Your radiology friends would be very, very helpful. This would be a hard example. I can't look at that as a non-radiologist and tell you if that's a grade 3 or a grade 4. So this was deemed a grade 4. I'm not going to have you grade these on an exam. I will give you the grade that they are and ask you to be able to manage that. I'm not trying to train you to be radiologists. But just an example, you can see it in the bladder, all the way up the ureters and extreme dilation. 1 and 2, when you just have the retrograde, but you have no anatomic response, so it's all physiologic, those ones do much better. When you start to get into 3, where you have some anatomic response there with the dilation, that's when you think, oh, this could go either way. And then 4 and 5, extreme dilation or tortuosity, certainly when you have more likely that you're going to need surgical management to handle this. Most of the time, if they're going to outgrow it, meaning their bodies and the UVJ obstruction and the maturation process, and their body kind of can figure this out, it's going to be by the time they go to school. Otherwise, probably not going to. That grade 3 then is the hard one. That's where there's a lot of provider brain that comes into that. Which way are they going to go? Are they younger? Are they older? Is it on the grade 2, 3 side, or is it on that grade 3, 4 side? So certainly, it's going to be better if they're younger and better if it's on one side. That should make sense. If they're older, hasn't resolved, and it's bilateral, you're going to have a worse prognosis for those grade 3s. So anytime you do a VCUG, nephrology should be consulted. Anytime, doesn't matter. If it's positive for any of those grades, your lovely nephrology friends are going to be helping you out on this one. So what are we trying to do? We already know there's reflux. We're not trying to cut on these kids. We want to make sure that the filters get prophylaxed as much as they can to prevent infection, and then we don't want the renal scarring. So those are our kind of 2 objectives for these kids. We already know it's going to have retrograde flow, but how do we protect the kidneys? So that's where everybody, no matter what grade you are, gets these behavioral modifications. We want to promote enterograde flow. So we want to make sure they have timed voiding. We don't want it to sit there and have time to retrograde, so get it out in enterograde. That means we want more fluids in to have more that's going forward. More fluids, timed voids, take care of that constipation. And this would be the kid that if you know they have VUR, and they call into you and your office and say, hey, I think that there's a fever, I think there's some abdominal pain, I think something's going on. That's the kid you go ahead and put a UA in and you walk them in that day. Early recognition of these UTI symptoms. The ones that need antibiotic prophylaxis are the ones that you would also think are these surgical management ones. So grade 4 and 5 are the ones that you're for sure with these recurrent or symptomatic UTIs. You know because there's anatomic changes that they're more likely to have this, so they get the antibiotic prophylaxis. Grade 3, that's up in the air for everybody. I'm not going to test you on that. So Don't worry about 3. Please know 1 and 2, 4 and 5. Surgery and urology is going to be consulted for those higher grades if you really think that you're going to need surgical intervention. So, much like you needed to know optometry versus ophthalmology, please make sure you know the medical side of the house is nephrology, the surgical side of the house is urology. This is really hard to test, just in general, and it's pretty rare. So most of this is a little bit more for awareness sake. So you've had some exposure to it, but again, you'll see what I mean. We're talking about this, different types. When we're talking about polycystic kidneys, the kidneys have multiple cysts. So the amount of nephrons is going to be how many are working, we don't know. I don't really care, I mean I do care, but I don't really care about the autosomal dominant form because when does it come on? Middle adulthood? Don't care. Unless I find out that I have polycystic kidneys and then we're about to care. But what I care about is the autosomal recessive ones. Because this is the most common cause of kidney failure in a young infant. You can even see it prenatally. It's functionally these gigantic cystic kidneys that take the entire abdominal cavity but don't function at all. So they come out very, very sick, gigantic flank masses, proteinuria, hematuria, all the works, and these kiddos go to the NICU. You'll see a picture of that. This is how big they look. It takes up the entire abdomen, and you can see it on CT. It's super, super gigantic, but it doesn't function really functionally at all. So these kids are lifers for urology, nephrology, and most of the time a dialysis. You can have renal hypoplasia. It's very difficult to see unless you're next to a normal kidney. So one of those is normal, one of them is not. Guess which one has hypoplasia? The determining factor is going to be how many nephrons work. Right? So you might be small, but mighty. Or you might really be small and really not have that many nephron units that are doing a good job. So following kidney function here for these hypoplastic or dysplastic ones. Dysplasia is going to be worse than hypoplasia. Makes sense, right? It was not formed correctly at all. It's not just small, it doesn't work. So there is not much working kidney there. So renal dysplasia is another thing, very rare. And then horseshoe kidney, you see that some of the time when embryologically those two did not split off. So they are still connected. When you have that, you functionally treat them like they are one kidney because a hit to one is going to be a hit to both. So things to think about here, they still have 2 collecting systems, so 2 ureters, all of that is double, but they are connected, so they're functionally a single renal. So if you're thinking, ooh, do I need to let them play combat sports? What do I need to do with this child? If you know that they have one kidney, something to be aware of. The way they test this typically is this is a finding often seen in Turner syndrome. So just something to kind of pair those together in your mind. Something that if there's no problems, you don't need to go looking for, but something to be aware of, especially in kiddos with Turners. Testicular torsion when we're talking about these little boys. So we probably learned this in ER, you probably learned it in GU. We see this in our world because the anatomy went funky. So you will see this in little boys where, and often they'll always pair it with sports or something that happened. In real life, most of the time it's I was just sleeping or I was doing nothing and this happened because of the anatomy. So typically what will happen in this, I'm going to go to this one first, is the testes is typically oriented in a vertical motion. What happens with these kids anatomically is it's oriented in a transverse lie. So there's literally just more to tors. And so once it gets caught that way, it will kind of spin up like that, which is then why you see the exam that you do. Certainly if it's torsed, it's going to be higher. If it's already high and you try to elevate it, nothing will happen because it is still twisted, so it's a negative friend sign. And then that cremasteric reflex is not there again because it's already twisted and high, so there's nowhere for it to go. That's called that bell clapper deformity. because it looks like a bell where it's wide because of the transverse slide. If you think about it, when it is twisted like that, remember back to your anatomy, your venous plexus is cut off, thus you have lost the ability to circulate blood to and from the testicle. Things that don't have flow do not have grow. Back to block 1. That does not look good, right? That looks like a necrotic piece of tissue. That is what you are trying to avoid. So if you see something where you have, wow, one side is completely high, one side is very, very painful, it's exquisitely painful to these little boys, or certainly if you have any kind of color dysfunction, you should be running over the nurse and anyone else in your path to call urology. Things to think about though. If you have your positive friend sign, you're like, it's probably not torsion, it's probably something else, potentially infectious. If you had like an epididymitis or orchitis, it's going to be relieved with that pressure. Or you could see the appendiceal torsion. And I will say I've never seen this. I've seen it on every board exam. Every single one. Because it is trying to see, do you know the difference between those? So the testicle has this little tiny appendices on it, and that contors. And when that torses, you have this teeny tiny area of necrotic tissue. And that's what that blue dot sign is. Certainly if you have an incarcerated inguinal hernia, your exam should look different. You should be able to follow that through. It will still be very exquisitely painful. Again, I think I've seen this on every board exam, so just to make sure that you guys know it, the blue dot sign, you treat it NSAIDs, not with emergency surgery. This is the same as your adults then. This is a rapid, couldn't call you fast enough consult, because if you can reestablish blood flow, 90% salvage. If you cannot reestablish blood flow, almost universally loss of testicle. You get that ultrasound with Doppler flow. You see, is blood going in, is blood coming out? Both of those things. If you are looking and you're seeing this, there should be that color change. Certainly the more color change, the longer it's been. So concerning on the left, less concerning on the right, simply based on the color, even though the size is still substantial. A word, I'm trying to get through this, sorry guys. A word on cryptorchidism. So you have these undescended testicles. So back to embryology. As much as I love this, all gonads are going to start in your abdomen. Male, female, everybody. And they all go on a lovely little journey. So the female ones will journey down right to where they are in the pelvis. The boys will go and they will travel, they will go down the inguinal canal to end up in the scrotum. Something can happen on their journey. They do not get all the correct signals. Anti-Müllerian hormones, doesn't matter for our purposes, but if they do not get all the signals or something impedes them along the way, it will stop. And it is most common in boys, especially premature boys that didn't have full time for the journey. So if you're looking at this, 4.5% is actually pretty high in some males. You see it not infrequently where something doesn't make the journey. That's why it's imperative that you check at each and every well visit to make sure that you have 2 testicles and they are both in the scrotum. If they are not, they are too high, it is thus the temperature is higher, thus you worry about the cell differentiation. So they are higher at risk for testicular cancers and infertility. They haven't made that journey. And if functionally they haven't made the journey by 6 months out the womb, they're really functionally not going to make it on their own. So after 6 months, they need to be seeing urology. To have urology pull them down into the scrotum and tap them down. Number 1, that will help with normal development. Number 2, that will decrease the risk of testicular cancer and increase the risk of fertility. Got super into embryology here if you care about that. If not, that is okay. One final word on a testicular exam when you are doing this. Number 1, for the love of God, wear gloves. Weird picture. Number 2, you are feeling at the top of the inguinal canal and you are following and pressing down on the inguinal canal to see if you can palpate the testicles into the scrotum. One thing that will happen, particularly with babies, is that you will end up with retractile testes. So they will just functionally go back up into the canal. If you can can get them down to the appropriate place in the scrotum, you are good to go. That is called milking the testicles. So if you're in clinic and someone was like, could you milk the testicles? And you stare at them like, what did you just ask me to do? They've asked you to do a testicular exam to see if you can get the testicles into the scrotum. And I think on that note, it's telling me to stop talking. Y'all's faces are telling me to stop talking, so we'll finish the very last bit. Or do you guys want to finish it?
If you finish it out, man, we're down.
Okay, you guys told me to. Then, so the opposite. So we didn't have testicles in the scrotum, now we have extra fluid in the scrotum. So you can have two types. One, the fluid connects to the peritoneum, and so it's connecting, it's communicating. And one, it is not connecting, so non-communicating. If you're transilluminating this, it should see right through it. So it should look like, see the light through it. If you have bowel there, if it is an inguinal hernia, it will not transilluminate. So if it's just liquid, you are seeing that. Reminder what communicating versus non-communicating would look like. When it goes directly to the abdominal compartment, it is communicating. Your non-communicating, because it is kind of on its own island, it's going to be relatively stable in size. The body will usually absorb it. So you will see it a lot of times. Newborn babies, they'll come out with a large hydrocele. The body will usually absorb it. However, if it persists, urology has to go in and drain it. That is different from your communicating one. Because it communicates with the abdomen, you're going to see it regularly fill up, and depending on gravity. So after they've been laying down in the morning, smaller. After the end of the day, larger because of gravity. Urology basically functionally has to go in all the time to sever that communication. Penile abnormalities. So we're going to do hypospadias, not epispadias. So when we're talking about this, remember your anatomical positions. So for an anatomical position, that is an erect penis. So we are talking about the ventral surface, not the dorsal surface. So dorsal surface is going to be the epispadias. Leave for your rotations. So this is the hypospadias, more common. So while the journey didn't happen sometimes for cryptorchidism, for some young boys, we're also going to see that the urethral fold and the urethral meatus did not make the journey either. So you can see that function at anywhere along that ventral surface of the penile shaft. They will often, if one didn't make the journey, the other didn't either. So if you see undescended testicles, check for hypospadias. If you see hypospadias, check for undescended testicles. They are often cousins of each other. You can see this also with congenital adrenal hyperplasia. So if you see this in a female, it is actually very masculine because she had too much androgen, something that you can see as well. And this will require your surgical correction, so this would be an indication to completely stop your circumcision because they will sometimes use the skin of the foreskin to help recreate the urethral meatus. So don't take away their ability to do that for your body. Super interesting to me that we haven't changed the nomenclature for Apgars or anything like that for since the 60s. However, we have changed 6 different times of how we classify hypospadias. So the nitty-gritty of that is not as important. However, if you're calling urology to say, this is where I need a surgical intervention, the current guidelines is it on the glands of the penis, is it on the distal penis, or is it on the proximal? Which should give them an anatomical site location for how severe they're looking at a surgical correction. Most of the time, the way I've seen this present in young boys is they will have a urine stream that will just go in a different direction. So you would expect it to be going forward and it's going off to the side or it's going somewhere different. Most common way that I've seen this present, especially in uncircumcised boys where you're not just able to very quickly look at this. So anywhere again on that ventral surface. You're seeing it from the top also to worsening as you go from left to right. If you see this, stop what you're doing and call urology. It's not going to hurt or kill the child, but certainly needs to be corrected early to prevent any kind of other anatomic or UTI complications because their anatomy is not the typical anatomy. So when we're thinking about circumcision, it's probably truly the only elective surgical procedure in a child, maybe ear piercing, I guess. But truly, the things to talk about if a family says, well, what are the risks and benefits of this? Well, at the beginning of this, we talked about it's going to have an increased risk of UTI in that first year of life if you are not circumcised. So circumcision does carry a decreased risk of UTI in that first year. It also, if you don't have the foreskin there, to have phimosis or paraphimosis, then you don't have to worry about that. And over the lifetime, you will have a decreased penile risk. You have more of less aberrant cells that are covered up with another layer. You have less likely to have this. Things that are the risks or anything to do with any other procedure. So certainly there is a bleeding risk. So I do not do circumcisions just personally unless they've had their vitamin K injection because of a bleeding risk. Certainly there could be a poor cosmetic outcome. That's probably what we see the most. The outpatient procedure, and they are not happy with the cosmesis of this. And then always, though it be low, a low infectious risk here. So personal cultural decision to truly an elective procedure in pediatrics. A quick word, there is physiologic phimosis. So if parents are like, what do we need to do? What do we need to clean? What do we do? Nothing. Actively leave it alone. You don't need to retract. It will cause more irritation and balanitis with that. So you leave it alone and you allow physiologic phimosis to take over until puberty. What you worry about in puberty is the paraphimosis, so if you're retracting unnecessarily and you cannot get the foreskin back over. At that point, you would have to then not do an elective circumcision. It would be a required circumcision. And I will tell you, teenagers really hate that procedure. So, not a fun one. Last but not least, enuresis. When we're talking about inability to stay dry, we are talking about that in kids who are at the developmental stage. So if you said this 18-month-old has enuresis, I would tell you that is not at a developmental time where they would be expected to reach dryness. So their continence would not be at the developmental stage. Typically over about the age of 4 is when we really start to say you have enuresis. Primary, when you've never been dry in your whole life. Secondary, when you had a period of dryness and now you do not. Daytime, nighttime. So you can put any of those 4 combinations together. Secondary certainly tells you something was right and now it's not. So you start to look for a little bit more organic reasons if you have a secondary cause. Something else is going on besides your typical, I'm just young and I haven't matured yet. So your timing of this, your family history, it's wild. I think if one parent had primary enuresis, it's like 60% of the child will have it. And if both parents had primary enuresis, it's 95%. So if both parents were bedwetters, your child probably going to be as well, just statistically, epidemiologically. If you think about, again, secondary, you were dry, now you're not. So things that you typically think about here, certainly that I would, are you constipated and you've lost the signal? So that's the most common reason. Or do you have a reason that you're producing more urine? So second most common is going to be diabetes. This is one of the most common presenting symptoms for type 1 diabetes is new bedwetting. So that's one of the things that you typically see. First thing you want to make sure is you have not missed any type of infection. So your analysis to rule out, do I have glucose in the urine? Do I have an infection? And am I spilling protein? So kind of those 3 things to check. Preparing that always with a urine culture to make sure. And that will, again, address many of those underlying issues. Certainly, if it's negative and you're still worried about an anatomical reason, renal bladder ultrasound, and then ECG readings. So primary nocturnal. So they've never been dry and it's only at night. That type is most of the time that familial. I'm still young, I haven't matured, I have a family history, pretty standard, nothing to worry about. Secondary nocturnal, I'm sleeping so deep, I'm not getting the signal. I was dry and now something is going on. So So the most common reason for that is that they have OSA, so some sort of sleeping issue, or there's some psychological stress. We are moving, we moved overseas, there's a train right next to the house, now my sleep is all messed up. So it's really secondary nocturnal. When you have both primary day and night, those are the ones that they were never dry, and you kind of know this as a practitioner. These are the ones that you're having the older children, diapers, straight cats. There's something more developmentally, neurologically going on. And so your secondary day and night ones are really, so the top and the bottom are really where we focus. Primary ones, standard, run-of-the-mill, and your secondary day and night ones where you're like, wait a second, what's going on? This is new. I worry about diabetes. I worry about UTI. I worry about constipation, those guys. Obviously, you're going to treat anything underlying. This would be that one, treat constipation. It sounds weird. Treat all enuresis for constipation. So see last lecture. Clean them out. When in doubt, clean them out. If it's those primary type, they've never been dry, or it's the secondary type and you've ruled out other organic causes, your reassurance, every year, about 15% of these kids, as they get older, will get better. So you had 50% at the age of 4, when they're 5, 15% chance they're gonna get better over the age. So if they're still having problems, we can talk about that. But like 9 or 10, that's when they start. Let's look at this. Certainly, if they're snoring ENT, let's remove some of those tonsils, make it a little easier for them, and restricting fluid. Enuresis alarms, people think that those enuresis alarms are gonna like wake them up. They're gonna like, no, the kid needs to pee and wake them up. That's not how that works. Most people hate enuresis alarms because they go off when they detect wetness. So they detect that the child has peed, and then they either shake the bed or they have this like pulsating, loud, obnoxious noise. And it's a signal to wake up that they've already wet the bed. So most people hate them, even though they're very effective. TRICARE hates paying for them. Everyone hates them, but they're actually pretty helpful. Pharmacotherapy, there's a big debate. Do we use it? Do we not? Really, since they grow out of them, if it's primary nocturnal, we use that for rare circumstances. I'm going to camp. I'm having a sleepover. I'm going to grandma's for the weekend. So we use it in those situational times versus every single night. For the most part, we're using desmopressin, so a anti-diuretic to keep them from losing all of their fluids. There's some more, and some people are starting to use it every day. Still the current practice is to use it situationally. So if you're thinking about using it every day, make sure at least nephrology is on board. Not to hurt it. I apologize over time, those 10 minutes. Now we're done. We'll figure out when to do a review for block 2